All right, we're going to get started again. Good morning, everyone. My name is Ebony Boyce Carter, and I am an associate professor and high-risk obstetrician at Washington University in St. Louis, where I'm also the division chief of clinical research for OBGYN. I'm also the associate editor for equity at Obstetrics and Gynecology, which is the journal at the American College of OBGYN. I think that our opening panel did an excellent job of making the case. And now we're going to turn our attention to a pragmatic approach to address the challenges and opportunities that we face in including pregnant and lactating people in clinical trials. And what better place to start than with the voices of those who are most affected. So let's take a look.
Hi, my name is Danielle Askin, and I have psoriatic arthritis with 4 children. There was a lot of concerns that I had when I was pregnant and breastfeeding concerning my medications, and it affected my ability to properly manage my illness while also taking care of my family.
Hi, I'm Melissa Gorman. I am a mother of 2 and a nurse. And in 2010, when I was pregnant with my first daughter, I suffered a medical complication that forced me to make a difficult decision regarding taking a medication while pregnant and while breastfeeding.
Hello, my name is Sierra C.C. Colvin. I am program manager at the Well Project, a nonprofit who serves women living with HIV. I am a mother of 2 and a woman living with HIV for the past 13, almost 14 years.
My name is Amber Griffith, and I am a postdoc at the Washington University School of Medicine in St. Louis. And I've recently given birth to my daughter, Zayla, this year, January 26, 2022. And when I was pregnant with her, it was all throughout the pandemic. So the vaccine and how it affects pregnant women was really important to me at that time.
When I found out that I was pregnant in February of 2021, that was the time that I looked at the side of my pill bottle, and that is when I saw that this medication was not recommended for people who were pregnant. That was disheartening.
I was very lucky to have a mother as a doctor who was my provider, my rheumatologist. And when these medications were being proposed, she did explain to me that there are 0 studies done on breastfeeding on pregnant women and the effects that they would have on children.
I was really shocked to find there wasn't a lot of information available. It was pretty scary to make a decision based on a lack of evidence, and it was really hard as a nurse and as a patient to try to do what is best for my child without having science to back up that decision.
Very difficult decision. Had to figure out what I wanted to do, and it was a lose-lose because it was either I would have negative side effects for myself or my children would have negative side effects, or both of us.
If we can get the research, the support, the backing of, looking at birthing parents who are living with HIV and breastfeeding, I think that would change the trajectory of where all of this is going.
My neurologist presented me with a great opportunity to participate in a study that she was doing to look at the safety of seizure medications during pregnancy and lactation. And it was a wonderful opportunity for me for several reasons. I wanted to help others who were in exactly the situation I was in a few years before when I was pregnant with my first daughter. And my husband and I had to make decisions about taking a medication when there wasn't a lot of information available.
These are conversations that I think doctors should have with their patients, to emphasize that, we're not just doing this, pulling things out of thin air and then just giving it to people. Like there's a process to this.
Patients can contribute to the process by, first, we need to be aware. A lot of times we don't know the things that are going on, any trials, any research, if no one's sharing it with us. And that would be, I think, one of the most beneficial things, because we do a lot of talking amongst each other, storytelling, and our actions can influence our other peers. So if we have the information, if we've been told, then that just opens the networks of people who are able to receive this information.
I want to acknowledge Danielle Askin, Melissa Gorman, Sierra CC Coven, and Amber Griffith, who are joining us both virtually and in person today. And Danielle and Sierra are in the room. Could you please just stand? Thank you so much for entrusting us with your stories. Like I said earlier, this session is about a pragmatic approach to including pregnant and lactating people in clinical trials. And in service to this goal, I'm happy to introduce you to a dynamic panel. Dr. Jakiba Henderson is the Senior Vice President of Maternal Child Health Impact and the Interim Chief Medical Officer at the March of Dimes. Dr. Veronica Gillespie-Bell is an Associate Professor, Senior Site Lead and Section Head of Obstetrics and Gynecology, and Director of Quality for Women's Services at Ochsner Health System in New Orleans, and Medical Director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review for the Louisiana Department of Health. And finally, Dr. Brittany Bettendorf is a clinical assistant professor and rheumatologist at the University of Iowa, where she runs a pregnancy rheumatology clinic. I invite you to go to page 24 in your briefing book if you'd like to learn more about our distinguished speakers. And with that, I will turn it over to Dr. Henderson.
Thank you so much, Dr. Carter. So I'm going to take some time to talk about the social and cultural considerations for including pregnant and lactating persons in clinical trials, specifically representing the patient perspective. So the historic and heroic efforts to bring COVID-19 vaccines and treatments to a world in the middle of a pandemic showcased our ingenuity in this country. And we all have already acknowledged that a crucial population was left out of that, and pregnant people. And now as a nation, we're really paying the price of that because of pregnant women's lack of confidence in vaccines, their inability to receive life-saving medications because of lack of information about them, and the inability and lack of evidence around the use of certain medications during pregnancy, as was demonstrated in the video testimonies that you just saw. And unfortunately, though, the CDC fully recommends that all pregnant people receive COVID-19 vaccination, as an example. A recent report just released by the Kaiser Family Foundation found that nearly 1 in 4 women who are pregnant or planning to become pregnant believe that pregnant women should not get vaccinated for COVID-19. The United States was already one of the most dangerous developed nations in our world in which to give birth before the pandemic. And we must take a lesson from this pandemic. Including pregnant women in clinical trials as soon as ethically possible allows for better data, early intervention to protect them, and early dissemination of public health messaging that dispels myths and misinformation. As an advocate for maternal and infant health, I fully believe that pregnant people should have the opportunity to choose whether or not they want to participate in clinical trials. I want them to have the best information from which to make these choices, and also want them to be armed with the very best evidence to be confident that the drugs and vaccines that they use are safe and effective for them. So as noted in a 2022 report on ethical issues in therapeutic use and research in pregnant and breastfeeding women, if pregnant people are excluded as a group from drug development trials, they're denied an essential set of resources and preconditions for their exercise of autonomy in making informed healthcare decisions. Autonomy requires both the removal of barriers to an individual's decision and providing the necessary support for that individual to make informed decisions. In addition to that, ease of access to information about clinical trials and the consent process that patients must engage with has been identified as a barrier to patient recruitment and retention. And if patients don't fully understand what is expected of them, they are more likely not to enroll in a trial and may also be more likely to drop out if they do enroll. In a recent qualitative study examining pregnant people's perceptions of risks and benefits of participation in vaccine trials, there were three broad themes that came out. The evidence, risk, and trust characterized their decision-making processes. And there was huge variability in how different types and levels of evidence impacted their considerations, which risks were most salient to their decision-making processes, and from whom they trusted recommendations about participating in research. And ensuring that pregnant people have adequate information to inform decision-making delivered by someone that they trust, and incorporating patients' priorities into trial design may actually facilitate their participation. While considerations of patient autonomy in decision-making, having access to information about trials, and receiving adequate information to make decisions to participate in clinical trials are all very important, it's also important to understand the potential burden or challenges that pregnant people face to participate in clinical trials, some of which was discussed earlier in our previous discussion. And we must work to address these challenges. Studies have shown that in addition to exclusionary policies and study criteria that limit representation of pregnant people in clinical trials, eligible patients may be reluctant to enroll in a trial due to a general lack of awareness, as one of our testimonies showed. In addition to a general lack of awareness, they may not even know that there's an opportunity to participate in trials. There are so few institutions and investigators conducting studies with pregnant people, especially in the communities where these people live. And this significantly reduces the number of people, patients, practices, or hospitals that may even be aware of a need for pregnant patients to be enrolled. In studies that have explored pregnant women and their perceptions and their partners' perceptions on inclusion in clinical trials, many pregnant people are reluctant to be included due to concerns or fear of how it will affect their pregnancy. And they are often more concerned about possible effects on their baby than even for themselves. But in addition to these perceived risks to their baby and associated fears, other factors have been identified as influencing the recruitment and retention of pregnant research participants. And these include community and social level factors, such as lack of provider-led promotion. There is evidence that shows that people are more likely to be engaged when their providers are engaged and they can receive information from their providers. Another potential barrier is study participation accessibility and affordability. Having difficulty even getting to sites where these trials are being held. And then the implications of the social network and influences from family, their community, and spouses, and information that they receive through the grapevine about the safety and the benefits of participating in trials. In addition to those community and social level factors, personal factors also play a huge role, such as time constraints. As mentioned earlier, pregnant people are just people. They're people who work. They're people who have children. They're people that have other duties and responsibilities that take up their time. They're people that have jobs that they may not be able to take time off from to participate in a trial. There are people that need childcare if they're needing to participate in a trial. And there are people that also have other issues in life, especially in addition to other potential medical conditions that they have to deal with and tend to that may impact their participation. And then the other factor that I think is really important, personal factor, is relationship with the study team. Having the level of trust or feeling like the information that they're receiving is true and it's valuable and that they see true benefit in their participation. There are so many potential proposed solutions to help overcome these barriers to help pregnant people make informed decisions about participating in clinical trials. And I look forward to discussing these possible solutions today as we move forward with this discussion. Thank you.
Thank you, Dr. Henderson. Dr. Gillespie-Bell?
Good morning. Thank you all for having me today. I am going to bring the perspective of including pregnant and lactating individuals in clinical trials through the lens of equity and diversity and inclusion. And I'm going to bring you my perspective, as was mentioned, as the medical director of the Pregnancy-Associated Mortality Review in Louisiana and as a practicing OBGYN. From the perspective of the mortality review, this time last week, I was reviewing the maternal deaths in Louisiana that occurred in 2020, specifically from cancer and from COVID-19. And in reviewing those deaths, there were many individuals that chose not to get the vaccine or to proceed with treatment for their cancers because they just did not have the data. They did not know how it was going to affect them. They did not know how it was going to affect their pregnancy. And as a result, they died. So when we're talking about including pregnant and lactating individuals in clinical trials, it is literally a conversation about life or death. And so I definitely look forward today to talking about what solutions can be proposed. From a perspective of equity, diversity, and inclusion, I have participated in clinical trials specifically around about treatments for uterine fibroids. A little bit different than talking about pregnancy, but talking about equity. So for those that don't know, 80% of Black women will have fibroids by the time they're 50, and Black women are more affected in their reproductive years. They have a higher burden of disease, and their symptoms are much worse. But the data that we have to date for many of the clinical trials do not have Black women represented in those trials. And so we are forced to take data that did not apply to that patient population to give counseling. I'm happy to say that for the clinical trial that I've participated in through several phases, 68% of the individuals in the trial identified as Black or African American. And I specifically think that is because the investigators chose, or the people that designed the trial, chose principal investigators that look like the patient population that they wanted to see in the trial. So when my patients come in and they see somebody that looks like them, there is a level of trust that is established. And so they were happy to participate and happy to know that what they were doing was going to contribute to the body of evidence that would help other women that looked like them. And then the final thing that I would say is we heard from the individuals in from their testimony as patients. And I would also add to that as doctors, it is my duty when I have a pregnant individual in front of me to counsel that patient on the best treatment for them. We are always trying to consider risk and benefits for our pregnant individuals. But I don't have the data, so I'm at a disadvantage. I was a big proponent for the COVID-19 vaccine for pregnant individuals, and I definitely promoted that and gave the information that I could to my patients and across the state of Louisiana. But when they asked me, well, what did the trial show? I had to be honest and say, well, pregnant individuals were not allowed to be in the trial. And so just like COVID-19, there are plenty of treatments that we are advising our patients on that we really don't have the data. And so we really need to be able to, again, for our patients and from the patient's perspective, as Dr. Henderson mentioned, to be able to have that autonomy to make the decisions, we have to be able to give them risk, benefits, and alternatives, and we need the data to do that. And so I look forward to hearing more as we discuss those solutions.
Thank you, Dr. Bettendorf.
Thank you. I'm so delighted to be here and engaging with all of you. So thank you so much. I want to say I echo everything my co-panelists have said so far, and the video that was played feels particularly salient to me. I'm a clinical rheumatologist, and in my practice, I take care of pregnant and lactating patients that have rheumatologic conditions. So these are things like, for example, lupus, rheumatoid arthritis, vasculitis, inflammatory myopathies. These are chronic diseases that have many novel biologic therapies on the horizon, particularly within the last decade or two. Things have exploded in terms of treatment availability that really helps improve quality of life and also improve morbidity and mortality. Many of these medications have unknown safety profiles in pregnancy and lactation. Typically, I see patients in their reproductive years, and I'll have conversations with them at a preconception counseling visit talking about the risks inherent in their disease process when they become pregnant. And so that may include things like a baby being born small for gestational age, preterm labor, preeclampsia, increased morbidity and mortality for mom and baby, depending on the severity of the condition and if there's end organ involvement. And then I order, any potential tests that I think are going to impact their care and impact the types of screenings that they'll need during pregnancy. And then I look at their medication list. And oftentimes this is the sort of trickiest part of the encounter, is figuring out, okay, if your hope is to become pregnant within the next year, then what medications need to go? Ideally, I want the condition to be under control for 3 to 6 months before the patient becomes pregnant, because we know from studies that is what leads to the best outcomes for mom and baby. If we can get that condition under control for 3 to 6 months before pregnancy on a pregnancy-compatible regimen, that they'll then continue throughout the pregnancy and keep their disease with either in remission or with low disease activity. However, when I look at that medication list at that preconception counseling visit, a lot of times I need to tinker with the medication list. I need to change it based on the available data. And maybe I don't. But the thing is, we don't know about a lot of these medications in pregnancy because they've not been well studied. And sometimes tinkering with it, putting it on a medication, changing the medication regimen to something that has been better studied in pregnancy so far, sometimes leads to a flare. And then I'm advising to delay pregnancy until we can get that flare under control. And maybe all of that tinkering didn't need to be done in the first place. Of the 172 drugs that were approved by the FDA between 2000 and 2010, over 97% of them had undetermined risk for use during pregnancy. And post-marketing, it takes an average of 27 years after market approval to generate evidence on the safety of treatment in pregnancy for a particular drug. So that is a huge time lag for this population, waiting 27 years for appropriate safety data. That's going to help us as clinicians advise our patients in the way that they deserve, that is evidence-based. So women face issues of compromised care, and pregnant patients face issues of compromised care during pregnancy due to lack of data about safe and effective pharmacologic treatments, and we really need well-designed studies that include pregnant and lactating patients. So I have been asked to speak to how do we recruit and retain pregnant and lactating patients in clinical trials. So I think in order to talk to this effect, understanding barriers and facilitators of participation is really important. We've talked about factors that can really influence recruitment and a little bit of the barriers that have come up already. I think of this as 3 different levels. So factors that facilitate recruitment are factors at the individual level, the regulatory level, and the community and social level. So at the individual level, it's going to be things like demographics, the age of the patient, the income of the patient, the education of the patient, the time availability that they have to participate in the trial, and how much time commitment the trial is requiring of them. Pregnancy-related health problems that they may already have, and then perceived research relevance to the patient and their condition, and then fear factors in. I'll talk about that too. On the regulatory level, we're looking at things like the institutional factors like IRB provisions, legal and liability issues of a particular institution, and then federal guidelines. And on the community and social level, things like how was the study promoted? What are the recruitment networks that were used? How accessible was the clinic and study site for the patient, and the social networking and partner influence as well. So looking specific at each of those levels, on the individual level, looking at patient barriers and recruitment to recruitment and retention, transportation and access to the study sites. I know Dr. Henderson spoke to that already. So particularly, this is going to impact our low-income population that may not have reliable access to study sites, and that's a problem with distributive justice and access to these trials. So thinking about having a study location that's near and readily accessible to lower-income communities, and also near public transportation stops so that we can encourage equitable participation across study groups. And then also another model that's been used is clinical research staff traveling to a region of interest to address transportation and time constraints for the patient. Time constraints, so using things like mobile technology. I think there's a spot for that in the future for study reminders, study questionnaires, dissemination of key study messages that can be time sensitive and also distributed in an easy way for patients. There's also the idea of, or the thought of access to care. So patients who lack access to regular prenatal care are also unfortunately going to not have easy access to trial sites. So oftentimes we use prenatal clinics to enroll patients, and that is one way of getting patients into the trial. But unfortunately, patients who don't get regular prenatal care are then going to not have that opportunity to participate in these clinical trials. So considering maybe opportunities for the use of community-based methods of enrollment, like engaging not-for-profit social and health organizations to help patients that are from these low-resource settings to become involved in clinical trials. Finally, there's the barrier of personal factors. So these are things like specific to an individual patient, the specific risk to that mother or fetus in their pregnancy, apprehension about taking medications during pregnancy, communications about risk and the way that that communication occurs. There's also this thought of risk distortion, which has come up already, and this is where a patient may overinterpret the risk of making a decision about taking a drug in pregnancy or an intervention in pregnancy without recognizing that by avoiding the decision or taking no action, it actually may carry greater risk than the intervention itself. And so these are very specific risks that need to be talked about, I think, on an individualized basis with the patient so that they can be properly addressed. It warrants a clear, informed, unrushed consent process with opportunity for shared decision-making and discussion. And this can also help with fear about research studies and also enabling trust with the medical system. So that brings me to the next thing, barrier of lack of trust. This may have to do with a lot of things. There's historical reasons for lack of trust in the research process that we've touched on already, talking about thalidomide, the Tuskegee syphilis trials. There's very real reasons why people of certain groups may even have more lack of trust with the health system as well. Thinking about how do we overcome this, there might be opportunity here for community health promoters. That has been shown to be effective in promoting pregnancy-related interventions like infant nutrition and breastfeeding, and so potentially touching base and tapping into those community health promoters to help as a recruitment and retention strategy for our trials, I think is an excellent opportunity. That community presence can help to increase recruitment and retention in minority groups. Using the community-based organizations as research partners can also help with getting targeted messages to specific communities and designing promotional materials that are culturally competent to help with recruiting minority groups as well. And then finally, thinking about the design of the trial itself and fostering trust. Sometimes randomization, even though it's excellent science, can be a problem in terms of patients who distrust the process of randomization. There's sometimes a lack of belief in equipoise, or they just like the idea that there's the presence of a placebo. So I think having very real, culturally sensitive conversations about this to help strengthen trust, understand the patient's beliefs and perspectives can help with that during the recruitment process. Finally, including and having the right people in the room during the conversation about study participation. One study found that recruitment factors among pregnant women, 82% of young women that were between ages 18 and 30 cited their husband's opinion as a significant reason for non-participation. So again, encouraging that all stakeholders and partners and spouses are in the room during these conversations to help kind of have informed conversations and understand barriers. There's also, I think, a role for focus groups with people in our pregnant and lactating population to understand their barriers and facilitators to participation so that we can have ongoing conversation about how to overcome those barriers. On the regulatory level, structural policy issues, the stringent regulation of clinical research protocols had been a historical barrier, and that we've made significant strides, I think, in recent years, and promoting the presumption of inclusion, I think, is a very key aspect moving forward. On the community and social level, this is something I didn't think much about until I started digging more into this, but we as providers and clinicians can sometimes be gatekeepers to clinical research, whether we realize it or not. And so the beliefs of treating physicians can actually influence the recruitment of eligible pregnant patients into clinical trials. And so making sure that we partner with investigators so that we fully understand the trial and we can discuss it appropriately with patients or get them to a person that can discuss it appropriately with them so that we're not closing that gate. Eligible patients may not enroll in a trial because their provider is either not aware of the study or because of their provider's own concerns about the safety of the study. So again, medical providers were a direct conduit for study promotion and effective recruitment, and the study teams really need to ensure that they outreach with their community partners and their clinicians so that we can be strong allies and advocates for enrollment. As a shout out to Dr. Chambers, who I see sitting in the audience, I love to send my patients to mother to baby. And so many of my patients are on medications that are not well studied during pregnancy. And this is an opportunity where if it's a situation where I feel strongly and after discussing with the patient that I would recommend they continue the medication because of their underlying disease process is very great, then these are situations where we need to build that data set and we need to track these outcomes. And mother to baby is a wonderful way to do that. So the clinician network can yield, geographic, ethnically diverse samples, and provider-based sampling methods are feasible and cost-effective. Motivators and facilitators for participation. There's a 2017 systematic review by Van der Zand et al. That identified pregnant patients' reasons for participating in research. And I found this fascinating when you're thinking about, do pregnant people want to participate in research? Many of the reasons that were cited were, I think, very telling. So aspirational benefits were commonly cited. So this would be like the altruistic reasons, the desire to help others, the desire to contribute to science. Also, collateral benefits were commonly cited, and these are things like services that the trial provides, like vaccination or a free ultrasound or opportunity to learn more about their pregnancy or their condition, or the enhanced care that one might get from being part of a study, or even things like I think Dr. Hale said, when they increased a credit card payment back to the patient. So that type of collateral benefit also can be a facilitator or motivator. And direct benefits. So this is another aspect that can be a key motivator is the direct benefit from participating in the trial to the mother or to the fetus from that intervention. So maybe it's a drug or a procedure that wasn't available outside the trial that they now can access. Third-party influence. So this is like the influence of the healthcare provider, the influence of family or friends or community networks. And then a final motivator would be a lack of inconvenience. So the trial was convenient to do. It was in an easy location. So mostly altruistic and personal reasons for willingness to participate. As Dr. Swamy said, pregnant patients are also patients, and they're also people, right? Methods of recruitment.
And can we open it up to the audience
sure.
and we can continue addressing all of these?
Too much.
Great. So I want to keep in mind that we also have. Oh, sorry. Thank you. We also have a virtual audience, and so we want to make sure that we loop them into the conversation as well. So why don't we get started with one of the virtual questions? Do we have anything?
So we have one. It says, in your opinions, what is the best way to track and share information on treatment and pregnancy outcomes by drug, by condition, or across all of these realms? And are there particular considerations for community-based practices?
Who wants to take this one?
I'll start. Just as an OBGYN, I rely heavily on ACOG and the literature that comes out from ACOG, and so I think that's a great way to disseminate the information, whether that be as in an academic practice or community practice for obstetricians. I think that's an excellent way. And then we also, being board certified, we have maintenance of certification that we do through the American Board of Obstetrics and Gynecology, and part of the maintenance of certification is going through the latest literature that is picked out by ABOG to make sure that even if you're not in an academic practice, you are aware of any changes to practice or any new information. So I think those are great ways to get that information out to providers.
I just want to add, in addition to having that source of information, ACOG, I agree, is like that's where we go for information on best practice for our patients. I just want to mention that patients often are looking for information as well. They want to know, what types of things are safe for them, how it impacts their health and their families. And so I think the use of patient advocacy and community-based organizations is a great resource for them. I know at March of Dimes, we try to provide information to patients directly through various programs and community-based partnerships, but also just simply having information available on the websites, being able to go on Google and being able to find reliable information from reliable sources about your specific condition or about what potential treatments are available and how it may impact your pregnancy.
And I think the other thing I would say to add to that, I did mention that ACOG and ABOG is a great way to reach obstetricians. I think as a medical community, we need to do more as being a medical home for patients so that the obstetrician is working with the rheumatologist. I see this a ton of times again in maternal mortality review where the obstetrician is not working with the mental health provider, and so the mental health provider is stopping medications because they don't know that it's safe for pregnancy. So again, we tend to swim in medicine in our own lanes, and we have to remember that we are a team for the patient and we have to work as a team.
That's a wonderful comment, Dr. Gillespie. I think that communication back and forth between the obstetric team, the maternal fetal medicine team, and then any subspecialist that the patient has is vital to caring for these patients, and also vital to promoting, appropriate clinical trials too, because one specialty may not know about, the right hand may not know what the left hand is doing sometimes, and that communication can really be key. The other thing I think, to help foster an informed culture of research in pregnancy, I think we could benefit from having, general information about just the importance of research on pregnant patients in family medicine clinics, in OB clinics, in midwifery practices, so that patients see this type of material in the waiting room and they might be more likely to ask questions. Are the trials relevant to me?
Are there any questions in the room? Right here.
Hi, Iona Munjal from Pfizer Maternal Vaccines. You talked really nicely about the influence that the support care team has on the maternal participants' expression of desire to participate in clinical trials. Particularly during the pandemic, though, they can't be in the room. Can you discuss how you expand that room to include discussions with the support team? And what we found in our clinical trials is that pregnant persons who have access to care issues, their support team also has access to coming into the room and being present for that ultrasound, et cetera. So can you just discuss a few strategies you've tried to sort of enhance the discussion with that support team?
I think this may not be a strategy, this may be a criticism, but I think one of the things that we saw during the pandemic, doulas as community advocates as well as patient advocates were not seen as part of the healthcare team. And I think we need to change our framework about how we think about doulas as they are an extension of the healthcare team. And the fact that we did not allow them into the healthcare setting, and I understand why, but again, they are part of the healthcare team. And so I think that would have been a great opportunity if we had worked with those community advocates, with the doulas as birth workers and community birth perinatal care workers, to encourage them to encourage patients to participate, or at that time not to participate, but to get the vaccine. And again, for us as the health community, the healthcare community, to think about those community workers as a part of the healthcare community and not just a luxury or just a person to be there.
I think advanced planning whenever we're having kind of key discussions is always important. So just like with anything, with a procedure, just like when you're planning ahead and like, how am I going to position the patient for the best chance that I'm going to get a good, tap on the wrist, for example. Same thing, how am I going to position the patient so that we can have the best discussion about their, the chance to promote this clinical research trial for this patient that I think may benefit them or that may benefit science in general in addition to them. And so maybe having a conversation ahead of time, either on my chart or telephone call to the patient, like, I think there's something we could discuss at the visit about such and such. Is there anybody you'd like to bring with you? Or if they can't bring them with them because of COVID, sometimes we can incorporate either, a telemedicine visit to the person, their loved one that they want to have part of that conversation or that has a stake in that conversation. Or sometimes even just a phone call. I have the patient call their spouse on speakerphone if I'm going to be talking about something that I think is really critical. But a lot of times we can make exemptions to those rules too, to allow somebody in the room if we know we're having a critical discussion, planning ahead.
Thanks. Do we have any other virtual questions? Is there anything in the virtual chat?
Gone. Someone asks, how long should newborns, along with their moms, be followed, monitored, given resources on a community level after birth?
I think we're all sort of just hesitating to answer that because I think there isn't one answer for that. I think it depends on what you're following them for and what types of outcomes that you're looking for, depending on what the therapeutic is and what potential impact that we think it has. But the goal in responding to that question is understanding and recognizing that there is a need to follow past for example, for pregnancy past the birth, for example. We need to have better data on what happens in terms of the infant during their infancy, but also looking more long-term and looking at the impact on development, looking at the need for early intervention, looking at other outcomes, and being able to link it back to mom.
Another point I want to make on that, it's Dr. Bettendorf made this point and Dr. Haas did earlier. I think when patients are making decisions, like, for example, the COVID vaccine, it's, do I get vaccinated or do I not? And that's not actually the choice. The choice is, do you get vaccinated or do you take on the risk of getting infection with no protection? And so I think this is illustrated really well by a JAMA article last week that looked at neurodevelopmental outcomes of babies that were exposed to COVID infection in utero and showed an association with adverse neurodevelopmental outcomes. And so those same patients that were saying, I don't want to do anything that could impact my baby, like get a vaccination, we're not thinking, but what does COVID do? So I think that long-term follow-up is really important. There were some questions over right here.
Thank you. Sabra Ankner from the Association of Maternal and Child Health Programs. I just wanted to kind of raise two things that I haven't really heard here that I think is on the top of our minds in a lot of settings, which is reproductive justice. I think in the context of why were pregnant people considered vulnerable, it was not about the pregnant person, it was about the fetus, and that's in that context who we care about. And in looking at laws that have come down around the country that are criminalizing pregnant people and their care providers, that in this conversation we need to be addressing that. Is a primary care provider going to be afraid to refer a patient to a trial that may be appropriate for them if that trial, if the patient miscarries or has another untoward outcome that may or may not have been related to that trial? Is there criminal liability now for that provider, right? And so we are entering, as we in this room are trying to progress towards more inclusiveness for pregnant people and seeing them as people, outside of this room, we are going backwards. And those things are going to come into conflict, and I think that we need to address that. And the other part, I've spent the last 2 years working with maternal child health public health agencies in developing telehealth and virtual services. And one of our mantras has really become, as we've seen things like no-show rates dramatically decrease, that patients are often not non-compliant with care. We are non-compliant with providing them with care. And in this context also, none of us would be in this room if we weren't getting paid. We ask patients to be in a lot of places where they're not being compensated for us using their bodies for research. And, so in thinking about, like, is the trial site convenient? We make them convenient to us. And, and that can't be first if we actually want to be inclusive. So just really thinking about is the reason people aren't participating in trials, is the reason that, the enrollment's lower, they fail, they were non-compliant with the criteria, we have to drop them. Is it us or them? And it's, so thank you.
So thank you for your comments. I 120% agree with everything that you've said, and we are at a crucial point, and from a legal standpoint, where I am also concerned, and it's amazing to me that I have to be concerned that I may go to jail for practicing medicine, and it shouldn't be that way. And I don't know that individuals have thought about these ramifications long term and thought about, as you said, just the downstream effect. I know before our state legislation, I've been asked, well, how do we reduce infant mortality? And I said, well, when you realize that babies come from mothers and you take care of the moms, that will take care of the babies. So you're right, we've so focused on the fetus, we have forgotten the mothers. And then to your point about telemedicine, I've also said in many situations we built a healthcare system around the healthcare system and not around the patients. And I've been saying this since 2020, that we need to think about in 2020 and now going forward, how do we bring care to the patient and not make the patient come to care? And so I do think telehealth is something that we should incorporate way more into clinical trials, with the understanding that it is not the end-all be-all, because we still have social determinants of health that affect the ability to access telehealth. And I've also said that we should drop the word noncompliance from our vocabulary.
Just to clarify, I don't see telehealth as a panacea. I just see it as
as another tool.
Not even that so much as like in the context of like, oh, it turns out when we bring care to the person, yes. they're there.
Yes.
Yeah.
Thank you.
Oh, really?
Okay, I'm just trying not to leave out the virtual people too. Was there anyone from the virtual room?
One more, it says, what are some practical approaches that we can take to address concerns about liability that researchers and clinicians may have?
We'll save that for the liability section.
Yes, exactly. Okay, we'll come over here.
Thank you guys so much. It's so great to have you talking about it because it's very rare that we hear it as a patient advocate. But my question is have you guys considered in equity and everything, the access of healthcare and the ability to afford different medications and how that could actually incentivize people to go into studies? If the copays are too much for normal medication that's out on the market, perhaps maybe having it covered in the trial will increase the likelihood of people to actually participate.
That is an excellent point. Particularly, in the field I work in, many of our medications are thousands of dollars. And so you make an excellent point that availability of the treatment at a cost-effective price or free from participating in the trial can be a wonderful incentive and a way for patients to access these medications. That being said, we don't want to, on the contrary side, have somebody that is pushed into a trial because they can't afford a medication that's standard of care, right? And so that is one of those distributive justice concerns that's very important to talk about and to think about as we're inviting patients to participate in clinical trials and making sure that what we're offering is the most appropriate thing for that patient. But yes, absolutely, I think the cost of drugs is a huge problem in terms of access. Thank you for bringing that up.
All right, other concerns? Anything from the virtual room?
Sorry. We have a question asking, what is one important piece of knowledge you want researchers to have on mind when they're designing studies in terms of participation of more diverse participants?
Have diverse people at the table. That's simple, to bring that perspective. And also having patients. A lot of the work that we do with our quality improvement in Louisiana, we have the patient's voice at the table because you're designing something for people, but you don't have those people at the table. So having a patient that's participated in clinical trials as part of the research team as well.
I would follow that up. I believe wholeheartedly in what you just said. And the other thing I would just add is that in planning and designing clinical trials, making sure you consider the patient's lived experience and their priorities. Some of the examples you talked about how telehealth made it more convenient for patients to participate. There are other ways that in the design and bringing the patients to the table and having diversity engaged in design so that when you're developing the trials that they're already built to meet those priorities and needs of the population that you're targeting.
Great. I saw someone over here. Oh, Dr. Swamy.
So I think one of the things that's important that was touched on about how we collectively care for our patients is actually getting us back to thinking about individuals of reproductive age and reproductive health planning, because there are, I think, particularly disparities in the individuals who are pregnant with medical conditions and have questions about what drugs to choose and not choose and enrollment in trials. And so we have to get to a place where we're planning health, planning when people choose to conceive and to carry a pregnancy or not, and when they're planning to do these things so that we can actually optimize what medications they are on and or what they need to be thinking about for their future. Because what I find is that suddenly people have not had the adequate counseling when they identify their pregnancy, because we, I think, are just getting to a point in this country where we're talking about reproduction in a more open way. And because many of our pregnancies in this country are mistimed or unplanned, people are not prepared. So I think that in that moment, the automatic thing is to stop the medication and not think about what we know about it or not think about whether there's a trial to enroll in and those sorts of things. So I do think we need to make sure that as we're planning research and trying to increase enrollment, research opportunities, as well as enrollment and retention, that we're also thinking about the research of reproductive age individuals and how we go into that with what happens during the course of conception as well, and lactation.
You brought up a very good point talking about preconception care and planning, and I think we can't really have that discussion without acknowledging that there are a huge proportion of reproductive age women who don't have access to that care. There are 54% of counties in our country are what we would consider maternity care deserts, meaning there are no maternity care providers, no maternity care facilities within their communities, within their counties. And so in order to have this conversation about planning and preparation, we have to be very careful not to put the onus on the patient, recognizing that they may not even have access.
Thank you for that. Are there any virtual questions?
So we have one that says, what are some practical approaches for addressing mistrust in medicine, particularly for when it comes to pregnant and lactating persons? For example, how should a practitioner consult a patient when there is a lack of evidence?
So I'll take a stab at this one. I think part of it is being honest. So in December of 2021, when the vaccines came out and we had no data in pregnancy, I started off the conversation by saying, we have no data. This is a data-free zone and this is why. But this is my opinion based on all of the data that we have before and what we know of pregnancy. And I hoped that in being honest and transparent and saying what we did know and what we didn't know, that they knew that I wasn't trying to coerce them or sell them a bill of goods, but I was giving them a balanced argument. And so I think that intention does matter and conveying in an honest way. It's kind of where I started the conversation.
I completely agree. I think that honesty is key in those situations, and saying this is what we know, this is what we don't know. And then also seeing that we're accountable to each other. So we're accountable to the patient for sharing our knowledge with what we know about the medication, but we're also seeking information from the patient and understanding their personal values and their personal preferences to kind of help reach a state of shared decision making so that we can make sure we're addressing all of their concerns. And that we're providing them with the best available evidence and making it clear where there are gaps in that knowledge.
Okay, well, we can come back into the room. Is there anyone else? Yes.
Thank you so much. I wanted to go back to what you had said about the criminalization of providing care to our patients and conducting clinical research. I'm curious because in my work, I've seen a lot of my study participants be concerned about sharing their information because they don't want to be arrested or criminalized. And I'm curious, especially with the patient population that I work with who are ethnic minorities who don't want to longer share the fact that they had a miscarriage or they had an abortion. Have you seen that in your work, and how do you talk about protection of their information and still showing that it's safe and it's important, that their participation is important because of their experiences?
I think those are definitely legitimate concerns. I see that in the area that I work as we try to recruit the Latina population in participating in trials or anything. I think for me is trying to, again, establish trust. Trust is the foundation of every relationship, and I think we've said that today several times. So trying to establish that trust, trying to ensure them that the data is protected and understanding what protection means. But even before getting into that conversation, acknowledging that their concern is a legitimate concern, so validating their experience. And then, just with everything that in counseling, giving the risk and the benefits and then supporting whatever decision they make to participate or not to participate.
Anything in the virtual room?
Someone's asking, how can we help to address some fears in the pregnant and lactating population surrounding clinical trials or just drugs and vaccines in general?
So, as I mentioned previously, there are different factors that patients take into consideration when they're considering whether or not they want to participate. And of course, evidence. So there, usually when you get to the point of enrolling a pregnant woman, there is usually some evidence maybe available, even if it's animal data or data from non-pregnant people. I think it's really important to make sure that they have all the information that they need so they understand, based on the evidence that's already available, what their potential risks are. And that's the second piece, that when patients understand what the risk and benefit profile it is. And some things may, be of a different risk to them. Things about their own health may not be considered as risks as they may think about their baby, or vice versa. They may value, the risk on their own personal health versus how it may impact their baby. And then, of course, making sure that they have all the information that they have. And we already talked about trust and how important that is in being able to allay fear.
We're rapidly approaching the lunch hour, but I think we have time for a couple of more questions. Do you have one here?
Good morning. Thank you all for your perspective so far. Anup Chawla from AstraZeneca. So I have a question from an advocacy perspective, which is that in order to engage providers to serve within a clinical trial, if we wanted to run a trial that engages pregnant patients, we would need providers who are comfortable serving as a partner within that study. But many OBGYNs are trained in community practice. They work outside of an academic health system. And even within the academic health system, in some settings, a lot of the time, even among faculty, can be devoted towards practice. So it can be difficult to find OB partners who are interested and knowledgeable about running clinical trials when you want to engage them. From your perspectives, what do you think the responsibilities are of different stakeholders, industry, government, the academic system itself, in terms of promoting better awareness of how trials are conducted among practicing OBs, and how can we diversify that knowledge base within community practice so we don't introduce biases into where we recruit when we solely look at academic sites?
That's a great question. I don't know that I have the answer. I can just give you my perspective as a practicing OBGYN. I have a clinical interest in fibroids. Like, that was when I was in college. I thought I was going to find a cure for fibroids. Like, I thought that was what I was going to do. And so I have put that out there in my institution. And so my institution has then looked for clinical trials that were about fibroids. And so that's how I got started into clinical trials. So I would say for academic institutions working with their research department, because from the academic side, our institution is always searching for grants and for funding opportunities and clinical trials and research. So working with those institutions to help them to identify the interests of the practicing physicians, I think is a way to work on it from an academic side. From a community side, I think, and I hope I'm not misrepresenting community physicians because I don't practice that way, but I think it's more about time because it is eat what you kill. And so if you can't show how you can put this into your practice and not take time away and lose money, I think that becomes more challenging. So I think developing models of care that show how you can incorporate those clinical trials into your community practice.
And I just had one point to add to that is not just in how it applies to clinical trials, but I think it's important for there to be networks within communities, within areas. When we think about connectedness regarding having the appropriate levels of care and how the acuity of care changes and there needs to be transfer, there should be similar networks of communication between academic centers and then satellite or other community-based practices where there's a flow of information so they know what trials are available. They know how it potentially can impact their patients and then could potentially participate and their communities can be a part of those trials.
And I want to add that this is not the way that historically we've thought about clinical trials, but I recruit patients in 8 community health centers across Missouri who are pregnant. And how do we do that? the relationship started 3 years before the grants did. So essentially, those community health centers were part of the process from its inception. They reviewed the grant. They helped to write pieces of the grant. Like, they were very involved. And so it was an in-depth relationship. So we went from going, like, saying we couldn't even say the word research because people were upset about it, to then them being excited. And then also figuring out, how does the research serve the community health center? Like, what sourcing do they need? What staff do they not have, so that it actually is enhancing their mission and not detracting from it with like a burdensome mission? And that's a ton of work. It's really hard to do. But I mean, no one else has been able to recruit successfully in these community health centers, and it's because it's their project. Like, they were with it from the inception. We have got time for one more question. No? Oh, right here.
Not actually a question, just a statement. I and of all of my friends that are also advocates, we found the studies through social media. So don't underestimate how important going to where people are, and not always are there community health centers. I live in Brooklyn, and we do not have a community center. What you do is you have insurance, and you go to where your insurance tells you to go, and not necessarily your doctor is going to talk to each other. So you need to be able to go to where people are, and people are on the internet.
All right, let's thank our panelists. And with that, I believe lunch is served. All right.